few other things I like to assess on a patient is I like to, if they have a C-section, of course, we want to see what the scar mobility is like. If there's restrictions, we need to work on that. It's gonna cause issues with the deep core engagement and back issues down the road if we don't get that moving. And then I like to see what happens if they lift both legs into the air. Is their core staying flat and down, or is their core bulging out? If their core is bulging, most people there's bulging, it means they're not recruiting their deep transverse abdominis muscles correctly. So that's another finding on the exam. A lot of times I'll also check for diastasis recti. So you go 2 fingers above the belly button, you're feeling the space at the linea alba at the belly button, 2 fingers below the belly button, have the patient do a little crunch, and then feel at those 3 spots. More than 2 fingers is diastasis, but if they have 1 finger, I mean, for the patient, that may be abnormal. So it doesn't mean we don't want to treat it. We may just say, technically it's not diastasis, but you do have abdominal separation of a finger, or 1.5 fingers. If you feel a bump at the belly button, that is likely a hernia. So that's something we want to treat with core strengthening. And then, let's see. Make sure to sink your fingers in. If your fingers really go in deep as you're doing the DRA test, that means they're not getting deep core engagement as well. The last thing I like to do manual muscle testing. I know it's not very functional, but I do like to assess hip adduction, either way with the leg, hip flexion, strength. I mostly just check the hips to see where they're at. Okay, if a pelvic floor exam is warranted for your patient, if they want their pelvic floor assessed, even if they don't have pelvic floor symptoms, we can do one. If they're postpartum, if they have any sort of leakage, constipation, pain with sex, any pelvic floor related issues, ideally we want to do a pelvic floor exam as long as the patient consents to it and is comfortable with doing one. So the times I don't personally do a pelvic floor exam, I don't do one first trimester of pregnancy. That's the highest, the time where there's most miscarriages, and some providers don't care for us doing an exam at that point. If they are having pelvic floor symptoms and they say they have vulvar varicosities first trimester, sorry, it's gonna be loud. I maybe would just visually look at the pelvic floor, maybe spring on the outer portion, just not inserting my finger vaginally or rectally. Let's see what else. So what we want to do is explain to the patient using the model what we're about to do, because most patients have never had a pelvic floor muscle assessment. So I like to get out the model, make it look very scientific, and this is my spiel. So we want to check out all of the muscles of the pelvic floor. So I just want to orient you to the pelvic model. So you can see this is the pubic bone, and back here is the tailbone. Your pelvic floor muscles are like a hammock from your pubic bone to your tailbone. And I'm going to use a gloved hand and then 1 digit to check all of these different muscles. So I like to start on the outer layer muscles. There's 3 layers of pelvic floor muscles: your outer, middle, and then your deepest layer of muscles. So using my 1 glove digit, I'm going to start by springing on the outer muscles. Just for orientation, this is where urine comes out, that's the urethra, this is the vagina, and this is the anus. So you may not know this, but the labia are actually muscles. So I'm going to start by kind of springing on the labia. What we do is compare side to side. Is one side of your pelvic floor really tight? Is one side really loose? Is it balanced? That's the main thing for the outer muscles. Or is that provoking symptoms? If I press on this ischiocavernosus, is that causing the patient to feel like they're leaking or feel like they're about to leak? That can give us clues as to what's going on. Okay, you can see how my map table is set up. This pillow is for the patient's head. I have the patient laying supine, their knees resting on the pillow. Then I ask the patient to butterfly their knees. They're still resting on the pillow. You can have knees up and wide. You can have a butterfly, whatever you feel comfortable with. So, say we're here, the pelvic floor, the patient's lying down. This way, okay. I have my gloved hand, and we're gonna get a decent amount of lube on the finger. And what I like to do, because the hardest part is like the insertion part. So I actually like to insert my finger just maybe to the first knuckle. And then I check the outer muscles. So I use my thumb. So I'm inserted. And then I'm gonna use my thumb to check the labia, check the ischiocavernosus, and I check then the superficial transverse with my thumb. And then ask about their symptoms. I just check the right side with my right hand, and then I do layers 1 through 3. I switch sides, and then I check all of the left side. You can really do it however way you feel comfortable, but it does save your hands if you are switching often. If the patient has vulvodynia, pain with sex, this might be all they tolerate. They might only tolerate you touching their adductor, and that's totally fine. That's all the info you need at that moment. If they're still doing okay, if they consent, we can go further in the exam. So then I insert my finger to the second knuckle, I check all the way around, I insert till the third knuckle, and then we're checking all the deep pelvic floor muscles, obturator internus, and we compare side to side. Then I check them for prolapse. So for prolapse, you're gonna put pressure on the posterior portion of the vaginal canal. Ask the patient to bear down hard. If you see tissue coming on the anterior canal, that's prolapse and you wanna grade it 1 through 4. Then flip your finger, have them bear down again. How much tissue, is there any? Do we have any rectocele? So this would be rectocele. This test is for cystocele. And then also this would be for uterine prolapse. If you see their uterus coming kind of straight down, that would be uterine prolapse. And lastly, I check the patient's strength. So I'll ask them to do a Kegel as hard as they can. Is there a squeeze and a lift? How strong is it? We're gonna grade the strength. And then I'll ask them to try to hold for 10 seconds. Can they hold for a full 10 seconds? Lastly, are they able to bulge their pelvic floor? And what happens if they cough? Is their pelvic floor like super bulging? Is it not? Some keys in the eval, we really need to validate what the patient is feeling. So if the patient says they have prolapse, they know they have prolapse, and you do your exam and you don't see any prolapse, think about how you would respond to that with a patient. Ideally, you don't want to just jump in and say, you don't have prolapse. I don't know what you're feeling. You want to agree with the patient. Maybe you would say something like, for the supine assessment, I saw some tissue laxity, not enough to grade it as a prolapse, but I can see what you mean. I can see why you're feeling those things. So you want to validate what they're feeling. Don't just dismiss what they're feeling. If you did see some prolapse and you agree with them, you have to be a little careful with describing prolapse because a lot of people are really scared of it. but you also don't want to downplay it too much that the patient doesn't think they have to come to therapy. If they're complaining of prolapse and you don't see it in supine, of course, we want to do a standing pelvic floor assessment for prolapse too. After we do the pelvic floor exam, then I have the patient get changed, come back, and then I come back in the room, and then we're gonna explain the findings of the eval, what the best treatment approach would be, and just kind of get the patient scheduled. Just some logistical pieces. Again, this is how I have my mat table set up. I have the fitted sheet on the massage table. I have 2 pillows. I like to have the patients very comfortable. You could put a Chuck's pad under the sheet if you want. You don't have to. If the patient says they're on their period, you would put the Chuck's pad on top of the sheet then in that case. And yeah, we go through a lot of laundry, but it's worth it for patient comfort. And then what we also do is we give how I would get a patient set up for an exam. I'm gonna tell them, okay, so you're gonna just undress waist down, and then you're gonna lay down with your knees resting over the pillow. Go ahead and put the sheet over your legs, and then you can ding the bell. We have a little bell in our room, and then we'll come back in and do your pelvic floor exam. Okay, I'll see you in a couple minutes. And tell them you're just gonna step out while they do this. So they know exactly what they're doing, they have clear direction, they feel very comfortable. And then when they ding the bell, you come in. I like to put a sheet over the patient, or they have the sheet on, and then I also do a towel over their waist. So then between the towel and the sheet, I can just, with a little pocket, I say I'm gonna make a little pocket, I can just reach my hand in there, and I don't even have to see anything or expose them at all. They just have that little slit that I get my hand in there. And of course I'll look too. You wanna look at tissue integrity as well. But the patient just doesn't feel like they're just out in the open. So after you're done with your exam, you're gonna let the patient get changed, and then you're gonna explain your findings. You may wanna share some of the findings during your eval. Say you're doing the core testing and their core is doming. You might wanna say, okay, so it looks like your core is doming. So it looks like you're not engaging your deep core muscles properly. So this is something we want to address. And you want to explain why it's important for their symptoms. If they're not getting great deep core engagement, what is that doing to their prolapse? They're using all outer core, putting a lot of downward pressure on their prolapse if they're not engaging correctly. Same with leaking. If their core is not engaging correctly, downward pressure. So you'll explain the findings. Maybe you'll say on your pelvic floor exam, it looked like you had a little bit of a bladder prolapse, and this is something we want to treat, and it's very important to get it taken care of right now. We don't want you to need a surgery down the line. So then explain all the findings, the importance, and of course read the room too. If the patient's like panicking, they might be able to not handle too much information. Maybe you just give them a few findings. The other important thing on eval is you want to elicit hope in the patient. So you want the patient to feel confident that you're gonna get them better. So we can say things like, we have helped hundreds of women with this issue, and we can get you where you want to be, or I can never guarantee an outcome, but I think you're gonna do really well, and I'm excited for you to get this prolapse under control, and I know we can do this, and I'm excited for you to get back to running comfortably. At the end, we want to take it back to the patient's main goals too, and get into the deeper why. So now we're going to talk about the deeper why. So the deeper why is never that you want to stop leaking. Like, why does the person want to stop leaking? And we need to get to that during the evaluation. Does the patient want to stop leaking because they're embarrassed that they leak? Is it holding them back from running races? Do they want to be able to fully participate with their kids? and the pain they're having is stopping them from doing that. So it's typically the deeper why is embarrassment, appearance, aesthetic. Maybe they want to look ripped. They want to look good for other people, for status. Sometimes they want to get back to a sport. Sometimes they want to get to be the best mom they can be. Some people want to fulfill like the wife role. They might feel like not a woman if they can't like have intimacy with their husband. So getting to that deeper why is very, very crucial to helping the patient understand where they can go and giving them confidence we can get them there, and getting them excited for what the future holds, and getting them bought into their plan of care. So we use a treatment method at our clinic called the MAD method, and it's mobilize, activate, and dominate. This treatment method on average is 12 visits, and it's broken into 3 phases. The first 4 phases are the mobilize phase, where we're working on maybe deep breathing, stretching, calming the nervous system, restoring the length of the muscles. The next phase is the activate phase, where once we have the full range of motion of the muscles of the pelvic floor, now we can strengthen and coordinate these muscles. So we want these muscles, if we start with just strengthening, if they're only going through a certain range of motion, they're going to be less coordinated. So I explain a lot of this to the patient. I say that we use a treatment method for treating cases at our clinic, and it's called the MAD method. It's based on the fact that it takes the body about 3 months to have significant lasting change. And the first phase is mobilize, and we're gonna get the tissue moving, because the pelvic floor is like a trampoline. We don't want the trampoline to be super, super taut. Like if you're already in a Kegel, how can you Kegel more? So we're gonna get the range of motion back, and then we're gonna strengthen once we have that full range of motion, and we'll have better coordination at that point too. And then the dominate phase is where we really take things to the next level. We test the system so much that the system can tolerate anything. So if you wanna, say you wanna run and not leak, well, maybe we're gonna have you jump on a trampoline and really test the system, because that would be harder than running on the pelvic floor. Can your pelvic floor tolerate that? We test it so much that you can tolerate any activity you want to do. And then this last phase is really where people get lasting relief. And we don't want people to have to come back for these issues again. We want to fully resolve them. I was going to mention too, another deeper why I just thought of is actually fear-based. So if a patient is like fearful because their mom had a prolapse surgery, that can be another deeper why. And so, yeah, we don't want to like scare patients, but we do sometimes want to speak to that deeper why and say like, hey, like I know you have a family history of prolapse. We really need to get your abs firing correctly so that this doesn't happen to you as well. And if you had a hysterectomy, you're a little more prone to prolapse. So we really want to get this situated now. So creating a little bit of urgency, and some motivation in the patients. So once you tell them about the treatment method, you've discussed your findings, you say, does that sound okay? Asking that question is kind of a micro commitment. They're just saying yes. Most of the time they'll respect your clinical opinion. And some patients I'll even say, hey, like 12 visits is kind of the minimum that it takes your body to change, and I truly think you're gonna need more visits than that, because you have bladder, bowel, and sexual changes, or you've had this for 20 years. Once we go through the treatment method, we ask, does that sound okay? And the patient says yes. then we say, okay, why don't we get you scheduled now so that we can get you back to insert deeper Y. Does that sound okay? And then as you're scheduling, you don't want to go every single week, because that can be very stressful for patients to be like, oh my gosh, this seems like a lot of visits. Like, then they're going to be more apt to say, like, why don't we just get the first 4 week schedule? Because I don't know what my schedule is going to be. All right. It's ideal if they came for their eval, say 5 p.m. on a Wednesday. Then if you can just say, hey, like, do you need these later times for your appointments because of your work schedule? Yeah, okay. Can we just stick to 5 p.m. on Wednesdays for your treatment? And then you just book every Wednesday for 12 visits at 5 p.m. Don't go week to week. That's very stressful for patients. Another thing, if they're objecting as you're scheduling them, saying, I don't know what my schedule is, then you want to create a sense of urgency and say, hey, just so you know, my schedule is like very booked solid. Can we at least hold these spots? Because I don't know if we don't hold them now, they're probably not going to be there in a couple weeks because we're getting really booked up. So that's a way, and you have them saved, and then you can kind of go from there. Before the patient leaves, typically, especially on that first day, I say, hey, is it okay if I charge your card on file? Just double check, because or you can even say, like, after you say that, is this an HSA card or an FSA card? Then they might be like, oh crap, yeah, I have an HSA card, can I use that? So it just saves them that. So just asking if it is an HSA, if they're paying on a card, and just double check that the one on file is the one you're gonna run. After every treatment visit, I wouldn't continue to keep asking this unless if you do have a doubt that that isn't the right card. We've had some patients where like each week they're using a different card, so you do want to ask in those cases. But for most people, if like those first couple visits they're using the same card, you can just assume for the other visits they're gonna continue to use that card. There's time for treatment during your evaluation. That's a good time to go through the diaphragmatic breathing exercises. You could go through some down training stretches, start some core, whatever you think is pertinent, some manual therapy. But yeah, usually good to do just maybe 5 minutes of treatment that first day if you can get to it.